So good evening, everybody. We are here from the EIZOC Secretariat for being a part of the webinar Ophthalmological Resident Teaching Series 29. ORTS will be giving us a platform for the young generation to come up with the academic activities, and as a whole with this type of programs, the bond between the different states of EIZOC will be tightened. Through EIZOC, Eastern India is gaining its position and repute in the National Ophthalmic Forum. Our Chairman Scientific Committee, Dr. Sabyasachi Patnaik, has framed the webinar in a meticulous way, guided by the Chief Coordinator, Dr. BNR Subudhi sir. The program is mentored by none other than our past President of AIVS, Dr. Ajit Babu Majji. The session will be moderated by Dr. Aparna Dwivedi. The speaker of the evening is none other than Dr. Kasturi Bhattacharya, who is a master in the field. She is a member ARC East Zone from Shankar Deva Netralaya, Guwahati. The topic being lead tumor and lead construction procedure. We also had a galaxy of panelists, namely Dr. Sharmishta Behra, Dr. Sonam Nisar, Dr. Varsha Bakalvati, and Dr. Devakanta and Dr. Sunil Kumar, who are even the masters in their respective field. Discussants are chosen from different academic institutions across the country, and their interaction will surely make the program a successful one. We are continuing with this type of webinar regularly. Lastly, our annual conference of EIZOCON 24 will be at Kalimpong on 29, 30th November and 1st of December 2024. I extend my warm invitation to all our esteemed faculties and the members to join and be a part of the great event. Thank you so much. Before continuing further, we'd like to hand it over to our proceedings to Dr. Pranab Ranjan sir, the President of the EIZOC, to give the welcome address. Over to President sir.
Thank you, Dr. Swaraj Bhattacharya. And I welcome you all on behalf of EIZOC as President to the Ophthalmology Resident Teaching Series number 29. The topic today is very interesting and very confusing also for general ophthalmologists, postgraduate residents, lid tumors and lid reconstruction. I said confusing and interesting because differentiating between a malignant and a non-malignant is of utmost importance. And for that, we have an expert speaker, Dr. Kasturi Bhattacharya, who is an expert in this field. The webinar will be moderated by Dr. Aparna Dwivedi, and in panel, we have got Dr. Shamishta Behra, Dr. Sonam Nisar, Dr. Varsha, Dr. Devkant, Dr. Sunil Kumar, and we have all the PGs and the residents from most of the institutions of the East. I'm extremely grateful to Dr. Ajit Babu Manji, who is the mentor for this webinar series, Dr. BNR Subudhi, the Chief Coordinator, who has been doing it day in and day out for the last few years, Dr. Swaraj Bhattacharya, our dynamic Secretary of EIZOC, and Dr. Sabyasachi Patnaik, the Chairman Scientific Committee of EIZOC. These words, I welcome the audience. I welcome all of you to have a great evening. So it's over to you, Dr. BNR Subudhi, sir, to carry forward the webinar.
Thank you, sir.
And in the meanwhile, if you have Dr. Sabyasachi, we can have a word from him, Chairman Scientific Committee. Dr. Swaraj, is he unmute, yeah. Dr. Swaraj?
Him as yet. Subudhi sir?
I think
Sabyasachi is not there, I think, na?
Yes, I couldn't see him. Yeah.
Okay, sir. Yes, sir. Please carry.
Okay. I think we can continue.
Yeah. My screen is visible?
Yes.
Yes, sir.
Okay. So I welcome you all once again to our EIZOC ORTS program. This is series 29. As Dr. Pranabji said and Dr. Swaraj has said, we are continuing this program for postgraduate residents, not only Eastern states, also other states of our country, has become now slowly become a national platform. And thank you, our EIZOC team, to allow us to continue this program in EIZOC platform. So today's session is none other than the speaker, Dr. Kasturi Bhattacharya. Everybody knows her, and she is well known amongst not only the Eastern Zone, also all over the country, nationally and internationally. Of course, she will be speaking today on lead tumors and lead construction procedures. This is our team of ORTS, and this is our EIZOC team. We are always supporting this program without any fail. So Dr. Pranab Ranjanji, President of EIZOC, Dr. Swaraj, Secretary EIZOC, and of course the master behind Dr. Sabyasachi Kotnai, who has designed this program in the COVID times. And of course, we got the mentor, Dr. Ajit Babu Maji, everybody knows him very well, and he has mentored this program such a way that we will get always very good speakers in our ORT series. And today's speaker, Dr. Kasturi Bhattacharya, as I told you, she is well known to all of us, and our moderator today will introduce her to the audience. Dr. Aparna is currently working at Dr. Agarwal's Eye Hospital in Bhubaneswar as a consultant for orbit, oculoplasty, and aesthetic services. And today's panelist, Dr. Sarmishta Behra, is always with us in either the ORTS program or orbit program regularly. She is with us. She is a professor, Bimsar, Burla, Odisha. And today's other panelist being Dr. Sonam Nisha from Associate Consultant, Sankarakala, Chennai. Dr. Varsha, she currently is in orbit and oculoplasty specialty, a chief surgeon, Sankarakala, Chennai. And Dr. Devkant, Associate Professor, AIMS, Patna, and Professor and actually BIMS Ranchi, Dr. Sunil Kumar. So these are the panelists. So the next few minutes they will be discussing with our speakers. And today's discussion, you see more than 13 students were there, and they have shown interest to join this program today. I'm really grateful to them. And this is Dr. Sonali Singh from Burla, Bimsar Burla, Dr. Subaya from JLN Medical College, Bhagalpur, Dr. Ekta Misra, she is also from JLN Medical College, Bhagalpur, Dr. Sasmita Panda from MKC Medical College, Berhampur, Dr. Smruti Ranjan Dhar also from MKC Medical College, Berhampur, Dr. Subhasri Saur from again MKC Medical College, Berhampur, and Dr. Lakshmi Saju, she is from Silchar Medical College Hospital, Assam, Dr. Renuka from AIMS Patna, Dr. C from AIMS Patna, Dr. Liju K from RIO SC Medical College, Cuttack, Dr. Rohit Kumar Mahanto, RIMS Ranchi, Dr. Arti Paul, RIO SC Medical College, Cuttack, and Dr. Amrita Venkata Subramaniam from Sankarata, Chennai. So we got a lot of post students discussing the topic with our speakers and panelists. So I will request our speaker today to interact with these students during a talk. So these few words, I welcome all, not only our EIZOC team, all the viewers who are behind the screen also to this interesting program. Now it is over to Dr. Aparna Dwivedi, and Dr. Sabyasachi is not there, and Dr. Ajit Babu will be joining a little late. We're going to start the program. It goes to Dr. Aparna Dwivedi to start the program.
Thank you, sir. Dr. Kasturi is easily one of the most decorated women ophthalmologists of India. She has won all the major AIOS awards, mainly the CS Reshmi, Colonel Rangachari, and E.T. Selvam. She is also a recipient of 55 national and international awards, including Asia Pacific Academy of Ophthalmology Achievement Award, the Best Paper Award. She has also been confirmed with the DCORT Fellowship Award. Being a prolific surgeon that she is, she has done some pioneering work in cataracts, refractive surgery, and oculoplasty. Her work in optic canal decompression in traumatic optic neuropathy has already been published in British Journal of Ophthalmology. Her innovative work on autologous biofillers got published in American Journal of Ophthalmology. She has more than 140 publications to her credit and 28 textbook chapter. The cherry on the icing to this very illustrious career is that she recently got her hospital management degree from Harvard Medical School. She is currently the director of Sri Shankardeva Netralaya, Guwahati, Vice President of Oculoplasty Association of India, President-elect of Asia Pacific Society of Ophthalmic Plastic and Reconstructive Surgeries Society, and member academic and research of AIOS ARC East Zone, and also she has been the global FRCS Glasgow examiner for the last 19 years. There is so much to learn from you, ma'am, but today we will focus on lid tumors and lid constructive procedures. So over to you.
Okay. And before Dr. Kasturi starts her deliberation, I would just like to mention that she is the jewel of the country and a pride of the East. So we are all proud of the fact that she belongs to the eastern part of India.
Thank you, sir. Thank you so much for the kind words and respected Pranab Ranjan, sir, Subudhi, sir, Dr. Sabyasachi, Dr. Swarajda, and everyone for giving me an opportunity to speak about the lead tumors and be with you all today. I'm so happy to see all of you, especially Dr. Sharmishta and my dear sisters Sonam and Varsha, both are here. And so nice to listen to everyone. And hope you don't get bored because it's a real long topic. I'm supposed to speak on the lead tumors. So I need to cover both the benign, malignant, the investigation, and the treatment. So when we speak about the lead tumors, we all know that these are basically benign or it can be a malignant. So benign tumors, the common ones are the sebaceous gland tumors, the sweat gland tumors, the melanocytic tumors, the neural tumors, the vascular, and the cystic lesion. The most important is that you should do a very proper examination. You should be able to diagnose whether it's a benign or a malignant. You should know how to characterize the eyelid tumors, and the most important, what are the different tumor treatment options for each of the tumor. Examination is most important, but before undergoing the examination, you have to do a very thorough, you have to take a very thorough history in all case, especially in, wait, let me know whether it is playing or not, regarding the duration, regarding when it first started. So what are the symptoms, whether there are pain, discharge, whether it has progressed or is stationary, whether it is persistent, whether associated with any other lumps, the multiplicity, the association, whether any there are systemic association, and most important, whether there are recurrences once it had undergone surgery. So local examination of every mass, it starts with these four characteristics. First, you need to look. What you need to look? You need to look to the shape, whether it's spherical, it's pure shape, or hemispheric or kidney shape. Where is the site? Where is an extension? You should always measure an eyelid lesion because you need to know the progression of the lesion. It can be measured by a simple scale, or you can also use the scale on the slit limb. The color and texture is very important, and the eyelashes. You should see whether there's any change in the eyelashes because it's a very important sign of malignancy. So, what are the other points that we need to look? We need to look at the base, whether the depth of the ulcer. We need to measure. We need to see if there's presence of granulation tissue, any slough, or any other malignant changes. This I have already mentioned, whether there are any changes in the eyelashes. What is the edge, whether it is rolled out? Because when we know it's a roll out edges, we usually suspect it to be a basal cell carcinoma. Whether it is everted, if it is everted, we suspect it to be a squamous cell carcinoma, and whether there are any presence of discharge or any blood or any purulin or any other stain material. So we really need to have a very strong eye. We need to look very, meticulously to the lesion. And in case it's a mass that can be felt, you need to check the temperature. You need to see whether there's any tenderness. The surface is smooth, regular, or nodular, and the edge that I have already mentioned. Always see the pulsatility in every lesion. You have to see the compressibility, whether it is reducible, especially whether it reappears on application of force, like when you ask a patient to cough, it has again come back. Whether there's fluctuation, which we usually do with two fingers, whether there's any fluid thrill, which indicates the presence of fluid. You have to see the mobility, whether it is fixed to the skin, whether it is fixed to the bone, or any underlying structure. So once you see all this, which I have already mentioned, look, feel, press, and move, next important, you have to do a transillumination. And this is what I mean to say. This is really important. You have to draw. Every student, all the residents here, you should draw, you should learn how to draw a lesion, note the lesion on the clinical evaluation sheet. Then also the other examination, which includes photographic documentation, is very important. You should know how to do a very good photographic documentation. And also you need to do some amount of systemic evaluation. In case you think that it is a vascular lesion, try to see if there is any groove within the lesion. Next, you should learn how to characterize the lesion. You should know what are the signs of benign and what are the signs of the malignant lesion. If it is slow growing over a few months and it has not undergone any changes, we usually consider it to be benign when it is having a very well demarcated border with the epithelium being intact, very evenly pigmented, and you have even eyelashes. But as opposed to do this, if you have the lesion which is growing very fast, it is ill-defined with an ulcerated epithelium, the lashes are gone or it is uneven, or there is uneven pigmentation, or the pigmentation has increased in diameter. So these are the signs of a malignancy. So the residents, you should take note of this, all the different signs of malignancy that I have already mentioned. Next, how do we classify? There are multiple ways of classification. There's some topographic classification. There's classification based on histopathology. There's classification based on the clinical signs, benign, malignant, or acute chronic. But what for our understanding is very easy if we follow this classification, which we very simply call the tumors of epidermal origin, the glandular and the adnexal tumor, the tumors having pigments, the melanocytic tumors, the neurogenic tumors, the vascular tumors, the lymphoid tumors, the xanthomatous tumors, the metastatic tumors, and other miscellaneous tumors. So I think the students, you can take a note of all these different types of classification that I have already mentioned, but you can go through the books. There are many other classifications. So what are the benign epidermal tumors? These are one, definitely the most common is squamous papilloma. Next is the seborrheic keratitis, the inverted follicular keratosis, the dermoid cyst, the keratoacanthoma, the actinic keratosis, the Bowen's disease. So these are all, they arise from the epidermal tissues, and that's why they're all called the benign epidermal tumors. So the squamous papilloma that you see here, the squamous papilloma is one of the most common benign lesion, which is usually seen in the elderly or the middle-aged. It has little rough, irregular surface that you can see here with keratinized crusting formation. It can be either sessile, you can see it can be little pedunculated. It can be, a single lesion or multiple lesion, or it have different types of color. The progression is usually slow growing. And if it is rapidly growing, you should always, because I have already mentioned, one of the signs of malignancy from the benign to a malignant is a growth, that is a progressive growth, irregularity of the epithelium, irregularity of margin, and also if there is changes in the eyelashes. So you need to follow every lesion. And in case it is benign, the treatment is usually shape excision. But sometimes you can also go for carbon dioxide laser ablation or a argon laser ablation. This is another very common, which is one of the most commonest lesion, which is a basal cell papilloma, which can also be known as a barnacle. Many people, especially the dermatologists, they call it as a barnacle. It is also known as a seborrheic wart. These are well circumscribed waxy lesion, friable and having a stuck-on appearance. And they have very characteristic HP, which is that they have the keratin-filled cystic inclusions, having a lot of acanthotic proliferation. So treatment is usually excision, whether you go with laser excision or surgical excision. So this seborrheic keratosis, that is a basal cell papilloma, is also known as a wisdom wart. Why it is called? Because most of the patient, many of you will be having at least one in your lifetime, mainly seen elderly age group. So it is usually called that those wisdom, wise people usually have it. And sometimes they have an increase in the numbers and size, and this is the classic, the lesser to a large sign, which you very often see in a OPD. And when you see there's so many keratosis coming along with lots of pigmentary keratosis, we usually consider there must be some underlying systemic malignancy. Another epidermal tumor is the inverted follicular keratosis. And as the term says, it is usually misnomer because it was initially thought that it comes from the hair follicle. But now it is considered as an irritated form of the seborrheic keratosis, and the treatment is usually a surgical removal. Actinic keratosis is something which we see very often nowadays because the other name is a solar keratosis. This is something serious because you should really follow up such patient because they are the precursors of the squamous cell carcinoma. Usually seen in elderly patients, especially fair skin patient. And also if there is increase in the size, then definitely you need to follow very minutely those patients, very frequent follow-up. And if it is an isolated keratosis, we usually treat it with either cryotherapy or curettage. So what is the key difference between the actinic keratosis and the seborrheic keratosis? Seborrheic keratosis, the other name is what? The wisdom wart, which I have already mentioned, that is a basal cell papilloma. So actinic keratosis is basically a precancerous lesion caused by the sun damage, while seborrheic is a benign lesion, is a non-cancerous lesion. And actinic keratitis is usually rough scaly patches that we typically see, and seborrheics are usually a well-defined appearance. So this is how we differentiate between an actinic and a seborrheic keratosis. Keratoacanthoma is we consider also as a precursor of a squamous cell carcinoma. So the characteristic is that they have a crater. You can see this is a lesion. They have a crater in the center, and these are the patients very often they go for a squamous cell carcinoma. So you need to observe it in the early phase. You can go for cryo extraction or cryo treatment, but the surgical resection and the biopsy is the best way to manage such patient. And the Bowen's disease, which is also something very serious, we also consider it to be seen, especially in individuals too much exposed to arsenic. These are also considered as invasive carcinoma, and the HP is very pathognomic. So these are some of the epidural tumor where dermoid cyst falls into both group. It can fall into cystic tumors, miscellaneous tumors, but it is also considered as one of the epithelial lesion, which is very commonly seen by all of us. And the best treatment of such lesion is usually excision. And then we have another tumor of epithelial origin, which is the epidermal inclusion cyst, where the best way is usually by excision. That you can see here, these are dome-shaped lesion. They are often pigmented. You can see these are dome-shaped and they are often pigmented. And the better you should usually excise such lesion. So from the epidermal, let us go to what are the sebaceous gland benign tumors. These are either the adenomas or the cyst. The sebaceous gland adenomas, they usually arise from any of the sebaceous gland, whether from the meibomian gland, the gland of Zeiss, or all the surface glands on the caruncle. They can be either benign, malignant, hyperplasia, hyperplastic changes. And when you have the caruncle, you should be followed them very, systematically and very religiously, such patient. Usually seen in a female in young adulthood, and sometimes they may have a systemic association, which we call the Muir-Torre syndrome. And these are the syndrome where they have multiple association, like the sebaceous tumors, the basal cell tumors, the keratoacanthomas, and usually they have a positive family history. The other variant, the other benign variant of sebaceous cell is a sebaceous cyst, which we always call a pillar cyst, because they usually appear in the region of the hair follicles, very slow growing, smooth, and they look like pillars, and the best management is excision biopsy. Sweat gland tumors, I think this syringoma is very common. We often see in many of the patients, this is one of the most common sweat gland tumors. The others can be a eccrine one, the pseudophorus, and the hydrocystomas. So these syringomas, you can say, I think you have seen, many of you have seen this, very common amongst your friends also. So these are the benign tumors of the sweat glands, and the treatment is either you go for the carbon dioxide ablation or argon laser. Sometimes you can also go by the surgical excision. And sometimes what we do, we just do a needle prick, and you can see some of the sebum type of material, it comes out. So it is definitely better to treat such patient. So these are the different types of the sweat gland tumors. And another sweat gland tumors, or we can also say, is this, sorry, let me go back. Okay, then we have the hair follicle tumors. The common are the trichoepithelioma, the trichofolliculoma, and the pilomatrixoma. So these are the lesions, and this is also, it is not uncommon. This we do see in a clinic sometimes, but this is more common, which many of us see in many of our clinic. So what are the melanocytic benign tumors? They can be the nevus, they can be the nevus of Ota, or the melanotic freckle of the Hutchison. So what is the melanocytic nevus? These are benign tumors. They derive from the cutaneous melanocytes. They can be either congenital or acquired. And you can see congenital usually appears after birth and shows a very slow pattern, and the acquired usually develops in adulthood. So they can be either congenital, acquired, they can be brown in color, black in color, they can be flat, they can be mildly elevated, and they can also extend beyond the mucocutaneous junction. Also, they can extend to the conjunctiva. There is a hormonal factor that is important. They can different types. It can be intradermal, it can be junctional, and it can be compound. So these are the different types of the lid nevus that we come across. The treatment is usually excision, and also you should go for biopsy. Kissing nevus, when you have the lesion in both the upper and the lower lid, this also needs to be excised. There are different ways. And we had done one publication in the British Medical Journal, and we have used the amniotic membrane to form this mucocutaneous. Not this case, like this is a different case. And you can see this is also a very nice way that we have done a publication few years back. Nevus of Ota, this is also not uncommon for us because we see subepithelial and the conjunctival melanosis together. This usually occurs along the first and the second division of the trigeminal nerve. Sometimes involves also the uval tract. When we talk about the neural tumors, the benign tumors, then that can be neurofibroma, that can be schwannomas, and the neurofibromas can be either the nodular varieties or the plexiform varieties. So plexiform, they usually follow the distribution of the trigeminal nerve associated with neurofibromatosis type 1. S-shaped deformity of the eyelid is common and usually gives a bag of wart appearance. So this is the typical S-shaped deformity that we see in neurofibromatosis. And also when you feel it, you'll feel it like a bag of worms. And then you have the other nodular varieties. It is not practically possible to remove every lesion because this nodular variety is not only on the lids, you'll see the whole of the body. So if it is possible to remove, you remove only those which is causing the cosmetic aberration. Very recently, we have seen quite a good number of cases of schwannomas of the eyelid. Like this, very interesting, even day before yesterday, I have operated a schwannoma of the eyelid. And this, I don't know if all of a sudden, like I think in the last few months, we have seen a very good numbers. Usually occurs in the adults, but we have also seen in many young children, they're solitary, smooth, very slow growing lesions in the lid or in the periorbital region. And treatment is, the surgical excision. But when we do the surgical excision of the schwannomas, it's very important that you follow the nerve. And in those cases where you excise the whole of the lesion along with the nerve, those are the situation which does not give any recurrence. But if you leave a little portion of the nerve, the chances of recurrence is very high. The vascular tumors, these are the long list of vascular tumors, which is a congenital capillary hemangioma, the acquired capillary hemangioma. Then you have the nevus flammeus, which we call the Portwine stain, the eyelid varix, and the lymphoma. So these are some of the common eyelid tumors, but also we do get AV malformation. I'm only concentrating on the common one, and this congenital capillary hemangioma is very common, which we usually see and which has a red or a purplish type of colors, spongy, it blenches on pressure. It is also known as strawberry nevus, and also it lacks the pulsation or any brow. There are different treatment, and you can see that it is associated with multiple systemic association. Phases is what we usually like to mention to all the students. What is phases? The posterior fossa malformation, then H for hemangioma, then A for the arterial anomalies, C for the coarctation of the aorta, the I anomalies, and the sternal clefting. So phases is an association of this capillary hemangioma. Others are the morphosis syndrome, which is usually seen with multiple cutaneous and visceral hemangiomas. Then the Kasabach-Merritt syndrome, which is associated with the thrombocytopenia. So what is the treatment? Most important is that this is a tumor which undergoes spontaneous resolution in almost 40% of the lesion by the age of 4. So we call it the rule of 4. By 4, 40% of the lesion usually undergoes by spontaneous resolution. And many times 100% also resolution seen in the first decade of life. So how do we all started initially? We used to give intralesional triamcinolone or betamethasone. Then also now the different treatment modalities have come. You can go for topical timolol maleate. You can also go for oral propranolone, which really gives a very good result. Interferon is also treatment, radiotherapy, and the surgical excision. They acquired, they are almost same. They are also known as the cherry angiomas. They are mainly pedunculated. They may bleed, and also they are compressible lesion. Then this is very recently we have seen this. This is, you can see, and ultimately we had done the excision. She had a lesion here, and this is a post excision, and you can see it was managed very well. So what is the Portwine stain? That is a nevus flammeus. This is superficial and deep dilated capillaries are seen. You can see it is usually seen in one side of the face, usually follows the distribution of the trigeminal nerve. So you can see how beautifully it has followed this distribution on the trigeminal nerve. Associated systemic is the Sturge-Weber syndrome and the Klippel-Tronaway-Weber syndrome. Then eyelid varix and lymphangiomas are sometimes difficult. Like on clinical examination is sometimes difficult where there's a varix and lymphangioma. So Valsalva is a very good way, And one of the best way of treating this, we all know this is sclerotherapy. Either you can go for bleomycin, or you can also go for other types of sclerotherapy. Even people give the doxycycline. But I feel in Indian scenario, we have lots of publication regarding the use of bleomycin. And when you have something like a Valsalva positive, we usually know this is a varix. And the best way of treatment of such is sclerotherapy, which usually how we do it, we use sodium tetradecyl sulfate. So this sodium tetradecyl sulfate, the STS, even like day before yesterday we have done, it really gives a very good result. And also you can go for a plus minus bleomycin. So bleomycin is something, a wonder drug that has come to our armamentarium for this management of sublymphangioma, eyelid varix, and also for a low flow AV malformation. Pyogenic granuloma is also considered to be one of the vascular tumors because it arises from the immature capillaries. So let us go to the malignant eyelid tumors. So if we look to this world map, what we see that in the Caucasian or in the North American and European population, BCC, that is a basal cell carcinoma, is very common as compared to the Southeast Asian countries, where we see a more of a sebaceous gland carcinoma and also some amount of BCC, especially in the East Asian countries. So the Western and Asian data have considerable variation in the case distribution and in the presentation. So when we talk of the malignant tumors, we usually divide into number one, the carcinomas. And these are the three very famous carcinomas: the basal cell carcinoma, the squamous, and the sebaceous. Number two, the sarcomas, which is the Kaposi sarcomas and the lymphosarcomas, and the malignant melanoma and the Merkel. And all the three that you can see that I have placed in red, these are the very lethal tumors. So these are the three main lethal tumors of the eyelids: the sebaceous cell carcinoma, the malignant melanoma, and the Merkel cell tumor. So if we look to the distribution, we see that in Asian country or in Southeast Asian country, the basal cell carcinoma occupies around 47%, the squamous is approximately 9%, the sebaceous gland is 30%, and the Merkel is melanoma is another 14%. So you should know how to classify, and this classification really helps you know about the disease, how it is progression. We all started with this TNM classification, which started from TX, that is no tumor, but T0, no evidence of tumor. T, that is a carcinoma, is C2, then T1, tumor less than 5, T2 between 5 to 10, and this 3 being more than 20, 3B extensive tumor, and 4 where the tumor cannot be removed because it has a spread beyond the eye and the lid to the cranial or the craniosacral structures. And then we know what is the N. The N0 means no regional lymph node, N1, the metastasis, and MO and M1. But based on this classification, what is the next important classification which has come is the UICC. This UICC is a Union for International Cancer Control Staging, and this is all based on the TNM classification. But the most important here, if you look here, it is almost like a TNM classification where O is a carcinoma in situ, and if you look to the tumor size like 5 to 10, more 10 to 20, more than 20, extensive tumor spread to the other part, only the T4 is a little different because it includes all the T's, and also it includes the N, and also includes M1 and the tumor that is spread to the other parts of the body. So this is what we follow for all the publication, especially in an OPD clinic. When we ask the fellows, we usually make it a point that they follow the UICC classification, which is globally accepted as the best staging for the eyelid tumors. So this basal cell carcinoma is a malignant tumor which is derived from the basal layer of the epidermis. As mentioned, it is one of the commonest tumor, and the main risk factors are ultraviolet radiation, advanced age, those having this basal cell nevus syndrome, then those having history, family history, and also those on immunosuppressive and also arsenic poisoning. So these are the patients who usually are risks for developing basal cell tumors, and this usually involve the most common is the lower lid, following the middle canthus, the upper lid, and then the lateral canthus. So it goes like this: lower lid, middle canthus, upper lid, and then comes the lateral canthus. So this, it follows a clockwise pattern. So they are very well circumscribed lesion They have the chronic telangiectatic lesions. They have a depressed crater-like center. So this is a very good way of knowing that whether it's a basal cell carcinoma. Different varieties, it can be nodular, it can be ulcerative, cystic, pigmented morphia, and the nodular can be again papillomatous, it can be nevus or cystic. So the most important thing that you can see this crater appearance which we usually see in the basal cell carcinoma, and this is also known as a rodent ulcer, right? And orbital invasion is manifested when it becomes non-mobile or when you have a frozen globe. So this is one of the very common lesion that we see. And the main important differential diagnosis for ulcerative nodular and pigmented, you should know this, I think.
Dr. Kasturi,
Yes.
why don't you ask one or two questions to the postgraduates?
Yes, so let me, yeah. I think we'll have a good discussion because I can see all of them like
Okay,
Pasha. Yeah. I think this they should take a screenshot more than me telling this. All can take a screenshot. These are the different differential diagnosis. The sebaceous gland in India, we see the sebaceous gland carcinoma very common, and they can arise from any of the glands which I have already mentioned: the meibomian, the size, and also the adnexal sebaceous glands. So it is more common in the female, mainly affects the upper lid. Recurrence is very common, and also it may have some systemic association. So, as I have already mentioned, it is a masquerade of chronic Calassian blepharochalasis and a blepharitis. So, if some patient gives you a history that I had a Calassian surgery twice, thrice, and it has gone for recurrence, you have to see, you have to check that whether this patient has gone for a sebaceous gland carcinoma. Like very interestingly, I know one of the patient has presented with chronic blepharoconjunctivitis. It was only conjunctivitis and there was nothing there, and some amount of blepharitis, and it was there for more than 3 months. And when we had done a biopsy, it came out to be a sebaceous gland carcinoma. So these three masquerade we should always remember, and we should always rule out if it is persisting more than 6 months. We should always rule out the sebaceous gland carcinoma. So what are the poor prognostic factor? Definitely when there's an invasion, diffused because they have a vegetative spread. So diffuse involvement of the eyelids when it has a multicentric origin or tumor size more than 10, and also symptoms present more than 6. Since you have asked me to ask a question to this resident, what do you mean by the vegetative spread? Any of the resident, can you tell me? Can you hear me? What do you mean by the vegetative spread that we see in the sebaceous gland carcinoma? Can any one of you tell me? It is an intraepithelial spread. See, I have used this. Can you hear me, all of you?
Yes, you can.
See, I have
Yes, ma'am. We can hear you, ma'am. Residents will be muted and this thing till we ask them to.
You can see that I have used the word the diffuse involvement. Diffuse involvement, how it involves? It involves by going intraepithelial spread. And this is known as a vegetative spread. I think I have one of the case I'll be showing you. So this vegetative spread, what is that? That's why every case of sebaceous gland carcinoma, when we go for operation, we have to do a map biopsy. I'll tell you what is the map biopsy. Then the next very deadly tumor is again the squamous cell carcinoma. And this is usually an aggressive tumor. It can be nodular, it can be ulcerative, and we have already mentioned that when there is actinic keratosis, this can be as a precursor of a squamous cell carcinoma. Melanoma, it is rare, but in my place in Northeast India, we quite often see good cases number of melanoma. It's really sad when you see the small children, small girls having melanoma. And this can be either flat, it can be ulcerated, it can be multilobulated, and these are really tumors because if it goes to the orbit, then there's no way out. We have to go for an exenteration. So a small lesion, if you suspect, immediately I think we should remove. If you have a small melanoma, like immediately it should be excised. And even frozen section doesn't work well for melanoma. It works very well for sebaceous and squamous. So if you have frozen section, it is good. Even if you don't have, you have to go for a very wide excision, approximately, I'll say always 4 or more. And then you need to excise this totally. You need to follow up this patient, go for a PET scan, because if there's any orbital involvement, then you have to end up doing an exenteration. The American Cancer Society has developed a very nice way, ABCD ways, as a guideline for diagnosis, where A refers to asymmetry, B refers to the irregularity, that is border, B for border, C to the color variation, D for the diameter. When it increases more than 6 millimeter, it's a sign that it is going, the nevus is going for a malignant change. And E refers to the evolving nature of the lesion over the time. There's a change that is having with the time. So this is what they call the ABCD guidelines by the American Cancer Association. And then we can classify it into lentigo malignant melanoma, the superficial spreading, the nodular, and the cutaneous melanoma. So clinical features of malignant melanoma is when you have the border irregularity with occasional bleeding, change in the pigmentation, and also this ulceration. Histologically, based on the level, the anatomic level involvement, that is the Clark's classification, based on the thickness, how thick is the lesion, that is known as a Breslau's classification. Anything more than 6 millimeter in the lid, we are suspicious. Merkel cell tumor, this is highly malignant tumor, especially seen in the Caucasian. They're dome-shaped, shiny tumors, and also they have the telangiectated vessels. So now that we know whether it's benign or we suspect a malignant from all the signs and symptoms and what I have already mentioned, feel, touch, move, and go for a good documentation. And other investigation that we're supposed to do is definitely one, a CT scan to know the spread of the lesion, whether it's involved the bone or any other structures in the around the eye and the lid, and also the MRI. So this helps us to have a very complete workup, and then we need to treat such patients. Any question up to here, or should we go for the management directly and go for the questions? Sonam, do you want to add something? Varsha, are you there?
Oh, ma'am, it's very beautifully covered, ma'am.
Okay.
Everything.
Yes, ma'am. We'll go to the management. Management is something one should really listen to it, because we not only there's surgical management, there's also non-surgical management, and this has come in a very big way. So what is the concept today? From the eyelid and globe sparing, we are going for vision sparing, for which the targeted therapy has come, and there are different targeted therapies, and which are the immunomodulators. So when we call targeted therapy, one of the common targeted therapy is what? The radiotherapy. So the situation where we go for radiotherapy, if the tumor is in the anterior orbital space, radiotherapy works very good, unless and until it's a case of some deadly tumor. But if it is in the posterior space, then also radiotherapy works good. And especially in the apex, it's not possible to do a surgery. So if it is in the anterior, we usually go for the surgery, or we can follow by targeted therapy, or if it is melanoma, definitely exenteration. But if it is in the posterior apex, we need to go for the radiotherapy and followed by other treatment option. So when I tell you about the radiotherapies are basically, one is the external radiotherapy and one is the internal radiotherapy. I will not go much into internal radiotherapy. This is the brachytherapy, which we usually do for the intraocular tumors. But when I say about the external radiotherapy, it is basically number one is the EBRT, that is the external beam radiotherapy, which was used very previously, almost 2 decades back. Now we have IMRT, that intense modulated, or IGRT, that is the image guided radiotherapy. Then other types of radiotherapy is stereotactic, which is either a gamma knife or a cyber knife. And the very recent one is a proton therapy. So these are the different radiotherapies which we all should know, that I have already mentioned, the brachy, then EBRT, that is external beam, IM means intense modulated, IG is the image guided, then the stereotactic, which can be a gamma knife or cyber knife, and the proton therapy. So these are the different radiotherapy. So let us know a little bit about the targeted therapy. So I have already mentioned you the most common are the basal cell, the squamous, the melanoma, sebaceous in the market. And what are the target? What are the molecular targets of this? If we know, then we will know what is the targeted therapy. So if we look to the tumors here, the basal cell carcinoma usually signals this hedgehog pathway. How does it activate the hedgehog pathway? Through the SMOs, that is the smoothen receptors. So, and even you look to the sebaceous, though we know that there's no targeted therapy for sebaceous, but there is also an activation of the hedgehog pathway in the sebaceous gland carcinoma. Squamous, definitely we all know it's the epidermal growth factor pathway. And the BRAF is basically for the melanoma, and for the Merkel cell tumor is the mTOR pathway. So based on this pathway, the signaling of the different pathway, the targeted therapy that has been come in today's scenario. So about 90% of the basal cell carcinomas, they carry a mutation in this gene, that is the pitch1 gene. So this mutation, what happens? It causes an overactivation of this hedgehog pathway via the smoothen receptors, and this leads to anarchic. This word is so specific, the anarchic cell proliferation that ultimately leads to a basal cell carcinoma. So anything which will decrease or which will deactivate this pathway will help in the treatment of basal cell carcinoma, which also I have also tried in many of my patients. I'll be coming to you. And this is the main hedgehog pathway, which there are different, treatment that is coming, which I have already mentioned. The two main genes are responsible is the pitch1 gene through the SMOs, what they cause when there is a UV radiation exposure. This damages the DNA. This leads to the pyrimidine photoproducts, aberrant hedgehog signaling. This ultimately stimulates the mTOR and other the smoothen receptors and ultimately leading to basal cell carcinoma. So what are the targeted which usually works against or deactivates this hedgehog pathway are the vismodegib, the sonidegib, and the imiquimod. Imiquimod is what is available in India, and I have also given to some of my patients. It really works good in those elderly patients where you cannot go for operation. Vismodegib, which is the best treatment for the as an inhibitor of the hedgehog pathway, this is not available in India, but this is where many of the Western countries they're using. And even one of our friend, Alon Kahana, he has given us such a beautiful publication where he has shown how vismodegib has worked in eye-threatening orbital basal cell carcinoma. So these are some wonderful drugs that has come out in the market. They have some disadvantage, which is very common for any of the other chemotherapeutic or the targeted therapy. So imiquimod, which is available in India, it can be applied locally. And this is also used for other like ethnic keratosis or melanoma in situ. They are also caused as an immune modifier, and which gives at least 60 to 75% efficacy. You can apply it 2 to 3 days a week, not every day. And this really gives approximately 5% is quite good for any of the skin lesion. Squamous cell carcinoma, which is the main pathway, that is the epidermal growth factor. Because of the activation of this epidermal growth factor, what it does, it also works on this P53, which already we all know this is a tumor gene, oncogene, right? So P53 tumor suppression ultimately RAS oncogene activation, and this ultimately leads to squamous cell carcinoma. So treatment is targeted to inhibit this epithelial growth factor activation, and the different, the medications, the targeted therapy that has come is the cetuximab, the erlotinib, and the gefitinib. So these are the main, the targeted therapy which prevents binding of the epithelial growth factor to epithelial growth factor receptors. And this way, what they cause the inhibition of this receptor, and thus it prevents the further progression of this tumor, the squamous cell carcinoma. Melanoma, which I have already mentioned, a very lethal tumor, and the target is a BRAF. So what the most of the medicines are targeted to this, BRAF, and also it works against mTOR gene. So these are some of the new medicine that has come out in melanoma. You can take a screenshot, the residents, and these are all the targeted therapy which has come out for the melanoma. And these are not available in India, but very soon I'm sure it will come to India. And especially in situation like this will be a great help for all of us. Now, for sebaceous gland carcinoma, there is no targeted therapy, though there are some clinical research which has shown that the hedgehog pathway is being upregulated, and that is why a sebaceous adenoma can convert into sebaceous carcinoma. And also they have used the application of this anti-SMO therapies, even the vismodegib that I have already mentioned, the people are using for the sebaceous gland carcinoma. But what I want to say that any sebaceous gland carcinoma, we have to go for frozen section. It is very important that without frozen section, we should not operate a sebaceous gland carcinoma if we do not have the setting, because I have already mentioned they have a pagetoid spread, the epithelioid spread. And the best way of knowing this, can you hear me? Am I
Yes, ma'am.
unnecessary? I'm showing you how I am doing the map by. I'm talking in estimates of mind. So this is the lesion you can give. Any repeater? So these are the
This is one, huh?
13 points. That is 3 in the palpable conjunction, tarsal conjunctiva, that is the palpable. These are the points. Can you say 3 in the palpable, 3 in the bulbar, that is 6, and the upper lid 6, lower lid 6, that is 12. Then medial and lateral 13, 14 around the limbus. Superior and inferior 13, 14, 15, 16, and 1 in the caruncle.
Dr. Subhashri Sahu, please mute yourself.
4,
So
5,
this is what
6,
you can see. These are the
7,
lesions
8,
out here. That is, I have taken 14,
10,
but you
11,
can also put 17.
এটা কাম
So,
কৰক। আমি ইয়াত থৈ কৰা তাতে।
নহয় চকুটোৰ লগত মিলাই দিলো
চকুটো চকুটোৰ লগত মিলাল।
So you should always remember, let me draw it here, that minimum 17 points should be taken for map biopsy. Like in the tarsal conjunctiva 1, 2, 3, then upper lid, lower lid 4, 5, not very good in drawing 6. Then in the bulbar 7, 8, 9, okay, upper lid. Then bulbar con 10, 11, 12, okay. Then this is a cornea, right? So 13, 14, 15, 16 at the limbus, 17 at the caruncle. So whenever you do a map biopsy, it is very important that you should do a map biopsy whenever you go for sebaceous gland carcinoma. Merkel cell tumor, which we do not see much here, it is more seen among the
Your
cochlear.
audio has come down, I think. Dr.
Hello?
Kasturi, Dr.
Uh-huh.
Kasturi, audio. Yeah.
Can you hear now?
Now you can hear it. Yeah.
So these are the 17 points that I have shown you. This is for the sebaceous gland carcinoma because they have a intraepithelial spread, which the other term is a pituitary spread. Okay. Now I'm talking about Merkel cell, which is not much present in Indian scenario, especially seen in the white skin people, the Caucasian, and they have also come with a targeted therapy, that is PD-L1 expression is there, and this evolumab and the pembrolizumab. These are the targeted therapy, but the radiation is also, they are also, responsive to radiation therapy. So now I'll just go into their other adjunctive therapies like the cryotherapy, then the systemic chemotherapy, the nanotechnology that have come out, the lymph node dissection, and also the phototherapy, especially the small lesions which can be managed very well by phototherapy, the different type of the light intensity therapy that has been used for the different type of lesions. So now a little come to the surgical management. Surgical management, which is very important for Indian scenario because many of the non-surgical, facilities are not available here. So what we need to do? We need to do a wide excision of the lid. Number one, we need to have a frozen section. Even if we don't have a frozen section, then once you excise it, send it to the pathologist for a biopsy. You can wait for at least 48 hours till the report comes out whether the margins are clear or not. Then you go for reconstruction. If you're not sure that the margins are clear of the tumor, it is better not to do a reconstruction. That is one principle. And second principle, the lid sharing in a tumor, you should be very careful. Without frozen section, you should not do a lid sharing, because I have seen many patients where a tumor was in the upper lid, a lid sharing like procedure has been done, Hughes or the Cutler beard, and ultimately the tumor from the upper lid has gone to the lower lid. So a frozen section or a good biopsy after operation is very important, because without this, if in case the tumor enters in the orbit, you need to end up with an orbital excentuation. So there is a definite algorithm to be followed when we do a lid reconstruction. One is which is a width based, which is the most common algorithm which many of us follow, which is based on the 25% increment of the eyelid width. I will tell you in details what is this. That if this width based algorithm, if it is a small defect, like if this is the lid, sorry, I'm drawing the lid. If this is the lid and this is a tumor, right? So we had excised 4 millimeter. Supposing this amount, this gap we are measuring, supposing 25% defect is there, then we can go for primary closure. If the defect is like this case is 50%, then you go a primary closure along with canthotomy and cantholysis. But if the defect is bigger, you have ended up doing a bigger defect in the eyelid, then you have to use either a graft or a flap. So this is a very simple way of knowing how to do a lid reconstruction based on the width. But a more better classification that has come on the base on the vertical height. which is we call the 1, and we divide it whether if it is involving the tarsus, not involving the tarsus, we call it 1A. If it involves the tarsus, the 1B, or a preceptal defect is there 2, or the lid cheek junction is involved 3, and all the whole lid is being involved, that is 4, which we have already discussed before the meeting about doing a master disc surgery. So if you have a vertical height base classification, if it is 4 and above, definitely you have to do the full cheek rotation. So you can also take a screenshot of this, like in case of upper lid, if a small defect, which I have already mentioned, that less than 25% or a full length defect, then you go for primary closure. If it is between 25 to 50, primary closure plus canthotomy cantholisis. It is more than 50, you go for flaps and graft. Likewise, in lower lid, the same. In a medial canthus, how we do if it's a small defect, large defect, or medium defect, and this is a lateral canthus. So this is what we follow in a routine practice, especially when we teach our fellows, like what are the surgery they need to do, especially when they do a tumor reconstruction. So when we talk about reconstruction, the reconstruction needs to be done on the anterior lamella, reconstruction of the posterior lamella, and the reconstruction of the whole of the lid. So anterior, supposing the tumor is a small lesion, a flat lesion, affecting only the anterior lamella, these are the situation where you can go for direct skin closure, you can go for Z-plasty, or this is a skin graft that I am taking this. You can see I'm getting a good split thickness skin graft, which I can use it to form the anterior lamella. But if you want to have a more thicker skin graft, this is full thickness skin graft. So this is the region, the post-auricular region. We usually take it a full thickness skin graft. And sometimes you also have a dermis fat here, which you can use it. And so this is where when you need a thicker graft, you usually go for the post-auricular region. If you need to reconstruct only the posterior lamella, so you need some mucous membrane. So the best way we take it from the lips. You can see I'm taking from the lips. Sometimes I take it from the buccal mucosa also, or the conjunctiva of the other side. So if you need to reconstruct a posterior lamella, best way you take it from the lips. Or if you need to do a more thicker, where we have discussed about the mustard, this is how you take a hard palate graft. And then you need not even suture. I never suture. I usually place a Surgicel, and you can see the bleeding is usually, if you do a good cauterization and place the Surgicel, you need not suture the lip or the hard palate. Only the buccal mucosa I usually suture, because the food particle may be adhered to the open wound and it might lead to secondary infection. So buccal mucosa suture with a chromic, suture with a catgut, simple catgut, or else you can leave it open. How we do a full thickness defect? Now you have removed the tumor and you have cut it nicely, and there's a defect, the actual defect, a full thickness defect. If it is less than 25 or between 25 to 50 in the elderly people, you can go for direct closure. And when you go for the direct closure, the best suture, what is? We give. Any of the resident, can you tell me what is the best lid margin suture? What is this I'm writing? Far, then take a near. Okay, this is the best lid margin suture. Do you take a bite far? Okay, this is a matrix suture, right? Far, then you go to the far end. Correct? Then the same suture near, then near. So this is the best lid margin suture. You need to align the margin so that you don't have any notching or anything else. So you need to align the margin, you need to align the tarsus, and then you go for the layered suture. Is it clear? If you have more than 50 or between or in the tighter lid, then we go for tensile flap. What is this tensile flap? It is a lateral advancement flap. So when you do a tensile flap, see, I have cut this tumor here. Now there's a big defect. I cannot close it. So this is how we fashion the tensile flap. For the upper lid, we take a curvilinear flap. We go down to the maximum to the lower orbital rim. Do not cross the lower orbital rim. For the lower lid, it will come in a reverse direction. Suppose in this, I will do it like this for the lower lid. Then you should not cross the upper orbital rim. Okay, is that clear? So this is how we do the tensile. And in tensile, it is best not to do a direct canthotomy cantholysis. You have to directly cut like this so that you get a very good alignment. If there's a large defect, then definitely we do lid sharing. One of the best lid sharing is the cutler beard. Or you can do a masterly lid switch. That is, if this is, I will show you what is a masterly lid switch. This is the upper lid. This is the lower lid. So defect is here in the upper lid. Best is cutler beard, which I'll be showing. That is, you take a full thickness from the lower to the upper lid. Or what you do, you need to switch this lower lid into the upper lid. This is which is known as master this lid switch. Or if the defect is medially, you take it from the glabellar region. Okay. So these are the different types of the flaps that we take for reconstruction. There's a small animation that you can see what is cutler beard. So there is a tumor in the upper lid. I have cut and I have made a big defect. So what I'm taking a full thickness tissue from the lower lid and transposing into the upper lid. And then after 6 weeks, I separate it and it gives a very good correction. So I'll show a small video. So this is a video in the upper lid. You can see I have done I have done a map biopsy. This I have already shown you. Can you see I have ended up cutting the whole of the lid. So now I'll be taking a full thickness tissue from the lower lid and then I need to make the posterior lamella. I'm taking the tarsoconjunctiva from the normal lid. Approximately 6 millimeter length of tarsoconjunctiva from the normal lid. I'm taking it. Then I'm making this tarsus of the upper lid of the defect which I have already created. Then what I'm doing, I'll be showing you this is a levator muscle. Now this tarsus, I'm suturing this levator muscle to the tarsus so that the patient has a good lid mobility. And then the tissue, it is coming full thickness from the lower to the upper lid. And then you suture it. And then what you do after 6 weeks or 5 to 6 weeks, you separate it. So this is at the end of the surgery. This is a cutler beard surgery. And this is now you will be seeing then how after 6 weeks, this is the same lady. I'm separating her. And then what I'm doing it, this is a separation of the lid. And then I will oppose this conjunctiva to the skin in the upper lid because there's a line of separation. So it has become raw, right? So I'm suturing the upper lid. And then the opening which I had in the lower lid, you need to freshen the edges and then suture into layers and you will see a very good correction. This is the second stage, which is usually done after 6 weeks following the surgery. And this is how, this is a lady, a very big lesion. And after doing this frozen section, we ended up cutting almost this much. And this is the tissue from the lower lid. It has been taken by the cutler bed technique and made the tissue of the upper lid. And this is how this lady, this is how she was before. And you can see there's no leg of tenderness. She can close the eyes so well. Am I audible?
Yes, ma'am. Yes, ma'am.
Yes.
More than an hour, I'll just finish fast. Under the lesion, you can see this is Akin exacerbaceous. So this big lesion, frozen section done. We ended up cutting lots of tissue, and again the cutler bed has been done. And this is, you can see the post-operative. So they have a good amount of function also. This is the, seeing it, you can, this is the pagetoid spread. See, there is a flat lesion. Can you see this intraepithelial spread? And then you can see I have cut the whole of the lid because the frozen section, every time we are sending margins positive, 4 times, 5 times, ultimately you end up cutting lid. So what I have done, I have taken some amount of tissue from the lower lid. I've used tarsus, sclera to form the tarsus of the upper lid. And then this is what you can see. This is at the end of the surgery. It looks so normal with such a big surgery. The whole of the lid was cut. Then you can see this is the lower lid tissue brought to the upper lid, and sclera has been used to form the tarsus of the upper lid. This another patient, you can see young patient, the whole of the sebaceous gland carcinoma. The first section says that margin involved, then you have to cut more till you get the free end, and then ultimately you say again I ended up cutting the whole of the lid. So no way out. So what I have done again, tarsoconjunctiva from the other eye, and this tarsoconjunctiva I'm making the tarsus of the affected eye. And then what I'm taking, I am taking a forehead flap. So you can place a flap over a graft. So one graft, the tarsoconjunctiva I have taken from the other eye. Now I'm taking the flap and I have put it over the graft, and so that it will give a good blood supply. And the ratio is 4:1. You should be very careful to know what is the length or breadth of this graft that you are supposed to take. And this is the gentleman, you can see there's no much leg of tenderness. See, the cornea is at least saved in this gentleman. And this is 6 months post-operative following this major surgery. So for the lower lid, we have to do in the reverse way. What is the lower lid? The most common is a modified Hughes flap, Or if it is a larger one, you have to take a more amount of tissue, which can be a mastoid cheek rotation, or we have a trippier flap, that is a bipedical flap, and also the Freaks flap also, which we take it from the upper lid to the lower lid. Small animation here. See, now the lesion is a lower lid. I have cut it and there's a big lesion now. I need to form the posterior lamella. So I'm taking the tarso conjunctiva from the upper lid. I will transfer this and form the posterior lamella of the lower lid. And then I will mobilize. I'm mobilizing the skin. Or you can also now put a graft, because this is a flap, right? It is a blood vessel. You can put a graft, or you can mobilize the skin from the surrounding tissue and you can cover it. Then after 6 weeks, you separate it and you will see a nice functioning lid with no much lack of thermus and good amount of function coming back. So this is a patient, you can see melanoma, the whole of the lid is being affected. Look at him, you can see it is so much. You can see there's involvement of this upper lid, involvement on lower lid, and up to this area, right? So this is a very big lesion, as you can see here, and you can see this whole lesion that has ended up in cutting so much. So I think Varsha had asked me, or someone had asked me, so what we have done, we have taken a Hughes place. What are remaining from here, we had taken a Hughes, and yes, this is the periosteal flap. Can you see this? I think just now someone has asked me. This is the, can you see? This is a periosteum taken, which has gone to both the lids, and these have formed the remaining tarsus. Is it clear?
Yes.
Yes, ma'am.
And now this is
Yes.
what I think we have just discussed, no, before the meeting. And then the medial, this is the glabellar flap. You can say I'm pulling tissue from every side. This is the forehead flap. And then the posterior lamellae from whatever little tissue I had, tarsoconjunctiva, and also the periosteal flap. And mastoids also, this is a very big surgery. You need to rotate it from here to here. And the posterior lamella, either you can take a tarsoconjunctiva from this side. I have very nice 2 videos, but if time permits, we'll show or we'll skip it. And now let me show this video. Why I'm telling is very important that you should not ignore any of the tumor. Prevent it before it spreads, because this is something very sad that I'll be showing you. This is a patient who had an OSSN, ocular surface squamous neoplasia. From the limbus, it has extended. Let me stop and show. It has extended to such an extent that the whole of the globe, and also there has been intraocular and orbital spread. And ultimately, we had to end up doing an exenteration. So this is what we don't want. We don't want a tumor from the conjunctiva or a lid to end up in an exenteration. And this is the exenterated tissue with a tumor in it. And then you need to do a very good cautery. And this is the surgical in order to close it. But what I want to show that even if you do an exenteration, we have to give this is the bone wax in order to control the bleeding. We have to do the best of best cosmesis. That's why I always tell all my juniors that you have to use a temporalis muscle flap. You cover the socket, otherwise it's so much of disfigurement. It leads to so much of psychological trauma. This is the vein spy that I'm using, which is used by the anesthetist. And then you see, you draw where are the veins. You try to avoid that area. This is not a very major surgery. It's a simple surgery. Give a nice S-shaped incision, expose the temporalis muscle, very vascular muscle. So you can use a good electrocautery or Elmeno, whatever you're using, radio frequency. Then you transfer the whole of the muscle and fill up the socket. If you have something filling up the socket, it gives a aesthetically much better. Like no one wants to have a hollow cavity because it is really very frightening for the other family members. So to conclude, I'd like to mention that the gold standard treatment of eyelid carcinoma is surgical resection with definitely clear margin. The development of targeted therapy against a specific genetic mutation in cutaneous malignancy have allowed for the destruction of specific cancer cell with less systemic toxicity. But the most important thing that all this treatment is still in the infancy, all the targeted therapy that I have spoken, we need more large-scale studies and more larger and longer studies to know what is actually working. But I still feel that the gold standard for every tumor is the surgical excision with a good biopsy, either intraoperatively or immediately postoperative. And this is the hospital where I work. This is the tertiary eye care center at Guwahati. And with this, I conclude. Thank you all very much for the patient hearing. I really enjoyed talking to you all and hope that I could contribute something to the understanding of this tumor. Thank you very much.
Thank you so much, ma'am. It was so comprehensive and beautiful. It was a refresher course for us also. I would like to request the panelists to add any of their experiences to the talk, and then we will move on to asking the postgraduates some questions.
Ma'am, fabulous talk. I think there is nothing that ma'am has left. I just like to add one thing for the lower lid. When we have a full lower lid is more static as compared to the upper lid, which is more dynamic. So many a times, if it is just about 3 to 4 millimeters thickness of the lesion, you can just leave it like a laissez-faire. That is just excise everything. You get margins negative. You can just leave it. There is generally no lag off. There's generally no exposure keratopathy. So if the patient is not very affordable, that is also another option. But obviously, we need to make sure that the margins are all negative for the tumor. That was just one thing I wanted to add.
Thank you, Sonam. So nice to have all of you. Sir, any question? Not to
Ma'am,
me.
one
So-
PG has asked, Sonali, he wants to know more about the map biopsy because it was not audible at that time.
Okay, map biopsy is basically meant for your squamous cell carcinoma because, as I have already mentioned, the squamous cell carcinoma is an intraepithelial spread, that is a pegylated spread, and it keeps on spreading from the eyelid to the fornix to the conjunctiva. So clinically, you might say only a tumor in the lid, but actually, by histopathologically, it has spread far beyond the lid. So you cannot just leave a tumor treating only the lid lesion. So what we do when we, along with excising the tumor, we take tissue from all around the globe because we know they can spread even from the upper lid to the lower lid. So the classical points are the 17 points where 1, 2, 3 in the palpebral conjunctiva of the upper lid and another 3 in the bulbar in the fornix. So 6 in the upper lid, right? So you have 6 in the lower lid, 6 plus 6, 12. Then you have this limbus. So limbus means superior, inferior, medial, lateral. You take another 4. So 12 plus 4, 16. And then 1 you can take from the caruncle. So that is 17. So 17 is what we take. The 17 approximately 1.5 to 2 millimeter. You draw it. Have you seen how I have drawn it? In the sterile, paper, you draw all the 17 points and you keep over each of the marking that you have given. Then you give it to the pathology and it should be given as a fresh sample. How we send it for frozen section, it should be sent like this. And then they will see which part is being involved or whether it has gone to the lower lid or the upper lid or the bulbar conjunctiva. And accordingly, you can proceed with the surgical excision. Okay?
Thank you, ma'am.
Ma'am, you had mentioned about a 4:1 rule to be followed for flaps, especially those which are taken from the forehead and the glabella. Can you please explain that again?
Yeah, if the lesion, the 4:1 means when you rotate the flap, no? So that the blood vessel is not compromised. Supposing if the lesion is 4 millimeter, then at least you have to take a long flap so the rotation does not give a 180-degree rotation. Can you understand? See, if this is my forehead, I want to take to lesion. It cannot be like if it is a short flap, it will lead to 180-degree rotation. Clear? If it is a long flap, it will give you maximum 30 or 40-degree rotation. So if the lesion is supposing 1 millimeter, it is not 1 millimeter, it will be at least how much? 10 millimeter or 15 millimeter into 4. That means you need to take a bigger one so the rotation is not in an acute angle. Is it clear?
Yes, ma'am. So this is true for all rotation flaps.
All rotational flaps.
Generally, like the base of the flap, as ma'am is saying, that has to be nice and thick because your main vascularity is going to flow in from there.
Yeah.
So,
yeah. Okay.
also on that, like Fricke's flap, like how ma'am showed beautifully, another way is we can tunnel it inside and just de-epithelize the tissue in that area and just then do it. I have seen Dr. Ennis do this many a times, though I take like the way ma'am you have taken, because I feel it's easier to then just, excise it. So once you de-epithelize it, many a times patients might be lost to follow-up and they might not come back to you. So when you de-epithelize it, just forms and becomes a part. You don't have to separately excise the flap.
Now, something else now, I don't know whether you're, because I also have that aesthetically, we have something MNRF, the Morpheus. You have something which is known as Adelaide. So Adelaide, if there's too much of thickened flap, no, you can also thin down the flap post-operatively. So lots of energy-based devices have come out, which has really helped us in the surface reconstruction. Surface resurfacing of this flap and the graft. Sometimes I also use those.
That's nice, ma'am.
Yeah. Even I'm planning to get this carbon dioxide laser because it really gives a very good service, resurfacing of the post-blepharoplasty or the post-flap, post-graft. It really does a very good resurfacing.
I think works fabulous for Indian skins also, right, ma'am?
Thank you so much. It's very elaborate talk.
I should also thank all of you. At least you all did not get bored. Me talking 1 hour, my throat has also gone.
It's very interesting.
Ma'am, what was the temporal vessels marking that you were doing in that last video that you had showed for exenteration?
See, exenteration, I don't like to keep it as a whole, like for healing by many people, let's say heal by granulation tissue, right? But it takes almost 3 months, I'm telling you. And you need to do everyday cleaning, hydrogen peroxide, betadine cleaning, right? So what I do, every patient I do a cover. Initially, I used to do all split thickness skin graft, but even the split thickness, no, because there's no vascularity, it undergoes necrosis. So
Yeah.
what I do,
Correct.
I basically use this temporalis muscle. I had done a very good publication in an Orbit journal. You'll see all the 3 different stages of how to do a temporalis transfer. Okay. But what I was marking is, you see the anesthetists, no, when they do the pediatric cases, have you seen they use a vein spy to see the pediatric vein? Have you noticed?
Yes, ma'am. Yes,
Ah,
ma'am.
same vein spy you use it and you see where are the major vessels
Yes.
because all the terminal branches of the external carotid. Yeah. So you have the superficial temporal, right? So you don't want to disturb those terminal branches. So if you can see because with every vein there's an artery also. So if you can draw it and very nicely you can see the vessels. So you draw it and avoid that space.
Okay.
Nice, nice.
It's just innovation and
So, PGs, if you have any other questions, if you don't ask questions, then we will start asking questions.
Sonal and Risha.
Yeah, first we need all of them to unmute and show us their beautiful faces.
We should see the
Only
face.
then, otherwise, all names will start coming. Samsung, SM, Sheetal's iPad, etc.
Good.
Fantastic. Now we're seeing beautiful faces.
Dr. Shamishta, would you like to add something?
No, it's nice. It was very elaborate and very interesting. I really enjoyed.
Thank you so much.
So, Amrita, Dr. Amrita, are you
If you
there?
ask me to talk about
Yes,
open
ma'am.
aesthetics, I can talk for 3 hours. But for tumor, 1 hour is sufficient for me. Though all of us, I think 50% of our practice for all the oculoplasty surgeons with tumors. Like it's so common in India. But you asked me to talk on aesthetics, I can talk for hours, 3 hours, 4 hours.
Okay, so Dr. Amrita, quickly mention few features which should help you distinguish between benign and malignant lid tumors. Very straightforward question.
Yeah. Benign tumor is slow growing. It has well demarcated borders and the eyelashes are normal and they don't have any pigmentation issue. While malignant is fast growing, has an irregular border, and usually there's loss of eyelashes or depigmentation or pigmentation.
100 out of 100. Okay.
Wait, one more point you missed.
Telangiectasia?
Yes.
Oh, yeah. Yes.
Okay. Dr. Sonali, if you can tell me the difference between actinic keratosis and seborrheic keratosis.
In seborrheic keratitis, we can see trillet sign.
I could not make that out. What did you just say?
When the lesions in actinic keratosis, there will be pigmentations, more pigmentations.
It will be rough and scaly.
And it is actually a precursor for the squamous cell carcinoma. And
Yes.
it is seborrheic keratosis. It is benign.
Any other name you call it by?
Then wisdom what?
Very good. Okay. And okay, who else is there? No one is showing.
The other name of actinic keratosis. So you have mentioned the other name of seborrheic keratosis,
Then
right?
solar keratosis.
Very
Yes.
good.
Very good. Okay, some questions about palpations and observation. How would you differentiate a squamous cell carcinoma from a basal cell carcinoma by describing the lesion?
Then according to the varieties, it is present as nodular, ulcerative, or morphiform.
No, you see the edges. Edges.
Yeah.
It is rolled out margin.
Which one is rolled out?
Then basal cell carcinoma.
Very good. And squamous cell is?
Squamous cell is everted edges.
It has everted. Okay. All right. Bag of worm feel?
Then plexiform neurofibromatosis.
And?
Neurofibromatosis.
Anything else that gives a bag of worm feel?
Varix, ma'am.
Very good. So we have two students who have listened very attentively.
Mm.
And others are not showing their faces. Okay. Who can tell me 3, 4, 5 points about capillary hemangioma? Rahul Jain, Rohit, anyone? Liju is also there. Liju can tell. Dr. Liju?
Yes, ma'am.
Yeah. Please tell me 4 points about capillary hemangiomas. What do you know about it?
So we say benign vascular tumor of infants.
Can you be more clear, please? There is some rule of 4 or something. When does it manifest? What is its natural course? And if you choose to intervene, then what are the treatment? That is all the headings that you should be answering.
Capillary hemangioma treatment is spontaneous resolution by the age of 4. And
All of them? All 100% spontaneously resolved?
no, 40%.
Very good. Okay. Yeah. And for the rest, which does not, what will you do?
Treatment like intralesional triamcinolone
Okay.
and oral propranolol.
Okay. Okay, ma'am. Thank you so much for joining us, ma'am. I think we will call it a end for today. Subudhi sir, Sarmishta ma'am.
Yeah, I think to call it a day. So,
Okay.
so it's once again I thank everybody, and I thank Dr. Kasturi to give me an elaborate picture, and it's a very vast subject, and we never thought that it will it will continue so much. But anyhow, you make so precise and given us a very precise note of everything. And I think all the postgraduate students have learned a lot today, and they will go home and they'll start reading the book. They will read review. And I thank our moderators, Dr. Sonam, Dr. Samishta, Dr. Devkant, Dr. Amrita. So all the postgraduates, again, I request them to come with the video, and always when there is a discussion, please come with the video, then it will get very much interesting. Last but not the least, the president and president-elect, both are here with us till then. So thank you, everybody, for joining us. See you next week. Bye. Good night.
Thank you.
Good night, sir. Thank you, ma'am.
Thank you.
Good night.
Kasturi. So the whole recording will be available on the YouTube. So anybody who logs in later and also wants to hear it, they will have it. permanently.
And best part, Kasturi madam will be sitting in another
Me too.
webinars after 9.